Alrighty, welcome to our session on wide complex tachycardia. I'm Ben Zoyomi. I'm one of the internal medicine PGY2s at BIDMC, and I'm joined by one of our senior electrophysiologists, Dr. Buxton. Thank you for joining me.
You're welcome. Pleasure.
In this session, we will review the definition of wide complex tachycardia and categorize wide complex rhythms. Then we will review the pathophysiology of ventricular tachycardia, supraventricular tachycardia, and pre-excitation. We'll outline common patient history and EKG elements that favor a particular diagnosis, and we'll conclude with a few practice EKGs. First, we should define wide QRS complex tachycardia. As we've reviewed in other episodes, the normal QRS duration is defined as 60 to 100 milliseconds, or 1.5 to 2.5 little boxes on the EKG. A wide QRS complex is defined as greater than 120 milliseconds, or 3 little boxes. If you see a persistent wide QRS complex rhythm on an EKG, you should think about 5 major buckets of etiologies. First, SVT with a permanent bundle branch block. Second, SVT with a rate-dependent bundle branch block. SVT with pre-excitation, ventricular tachycardia, or a toxic ingestion. I leave an asterisk here to note that the EKG changes in toxic or metabolic derangement, including but not limited to hyperkalemia, sodium channel blocker overdose, or digoxin or antimuscarinic toxicity, are numerous. These constitute a lecture on their own, really, so we won't spend that much time on these today. Let's start by distinguishing these two types of rhythms. As covered by Dr. Monroe in episode 7 of our series, a bundle branch block is a conduction defect in one or more of the 3 main branches of the His-Purkinje system, which are the right bundle, as well as the anterior and posterior fascicles of the left bundle. A permanent bundle branch block is a fixed conduction defect. That is to say, in a fixed block, the bundle becomes diseased and conducts no further electrical impulses. As such, the block is present at any heart rate. This is to separate this phenomenon from a rate-dependent block, which is a more relative defect. In this case, while the bundle branch is diseased, this manifests slightly differently as a prolonged refractory period, delaying the rapidity with which the bundle can repolarize and prepare to conduct another impulse. There is therefore no real effect noted at low heart rates on the EKG, but above a critical heart rate, the diseased bundle will not conduct quickly enough. This causes a rate-dependent bundle branch block. This distinction is important because patients may enter SVT and develop newly widened QRS complexes. Therefore, you can't automatically rule out a supraventricular rhythm in a patient with a wide complex tachycardia that has normal QRS complex width on a non-tachycardic EKG. In all patients with a wide complex rhythm, looking at previous EKGs is critical. Next, let's quickly discuss pre-excitation as it relates to wide complex rhythms. Pre-excitation is a condition where there is abnormal presence of an accessory electrical pathway connecting the atria to the ventricles. An atrial depolarization can therefore reach the ventricles through a pathway that does not involve the AV node. Remember that the AV node includes a certain electrical delay to prevent abnormally rapid impulses from reaching the ventricles. As a result, an atrial impulse reaching the ventricles through an accessory pathway causes premature firing of the ventricles.
It's probably more correct to say premature activation of part of the ventricles, because the QRS complex during sinus rhythm or during atrial tachycardias in people that have AV bypass tracts is the result of a fusion of activation over the normal conducting system and activation over the bypass tract.
Thank you, Dr. Buxton. There are several subtypes of pre-excitation, but we'll focus on the most common of which is Wolff-Parkinson-White, or WPW. The bottom left image shows both the normal expected conduction from the atria through the AV node to the ventricles, as well as abnormal conduction through an accessory pathway, shown with this red arrow. The accessory pathway in Wolff-Parkinson-White causes early depolarization of part of the ventricles, causing a sort of slurred upstroke of the QRS complex and effective shortening of the PR interval.
The shortening of the PR interval results from the fact that most of these AV bypass tracts conduct rapidly, similar to working atrial and ventricular myocardium, and not with the delay incurred by conduction through the AV node. The delta wave results because ventricular activation adjacent to the insertion of the bypass tract is slower than normal initial activation of the ventricles through the His-Purkinje system.
We can see this delta wave clearly in this EKG, most notably in lead 2, circled here, but also visible in lead 1 with slurring of the upstroke. This EKG is one of a young man with atrial fibrillation and Wolff-Parkinson-White. Note the wide complex rhythm with pronounced irregularity and absent P waves.
So this is what we call pre-excited atrial fibrillation. Wolff-Parkinson-White syndrome, that terminology refers to patients that have tachycardias that involve bypass tracts. Pre-excited tachycardias, a number of things should be noted. First of all, the most common pre-excited tachycardia that we see clinically is actually atrial tachycardias, including fibrillation or flutter or discrete atrial tachycardias in patients with bypass tracts. So during the atrial tachyarrhythmia, conduction to the ventricles is either exclusively or a fusion of activation over the bypass tract and the normal conducting system. The pre-excited tachycardias can be irregular, in which most commonly it's pre-excited atrial fibrillation, or they may be regular. And in addition to the atrial tachycardias that conduct with pre-excitation, we can have pre-excited tachycardias that actually involve the bypass tract as one limb of a reentrant circuit. Note that because bypass tracts usually insert at the base of the ventricles, either the right or the left ventricle, the QRS morphology during a pre-excited tachycardia mimics the appearance of the QRS in a ventricular tachycardia that is originating at the base of the right or left ventricle.
This becomes relevant to our discussion of wide complex tachycardias as we consider AV reentrant tachycardia, or AVRT. As discussed by Dr. Crawford in our narrow complex tachycardia video, the existence of the accessory pathway allows the possibility of a reentrant circuit. There are two possible directions this circuit can flow. The first is shown, where the atrial impulse flows normally through the AV node and the bundle branches before there is abnormal return of the depolarization through the accessory pathway, depolarizing the atria again. This is orthodromic AVRT, where the QRS duration is normal as conduction through the AV node and His-Purkinje system is occurring normally. However, the flow of the circuit can also be reversed. In this case, the atrial impulse travels through the accessory pathway first, depolarizing the ventricles rapidly with signs of early conduction, or delta wave. The impulse then returns upwards through the bundle branches and the AV node to close the circuit. This is an EKG of a patient with antidromic AVRT. We won't spend much time on the nuances of antidromic AVRT as it's quite a rare rhythm overall, but it can be quite challenging to distinguish from a ventricular tachycardia. Let's turn our attention to ventricular tachycardia. Ventricular tachycardia is a wide QRS complex tachycardia that starts in the ventricles. It can present either as monomorphic VT, where QRS amplitudes are all similar, or as polymorphic VT with multiple different QRS amplitudes. To diagnose it, you need to see 3 ventricular beats in a row. 2 PVCs in a row are called a ventricular couplet. Greater than 3 PVCs in a row, with a total duration of less than 30 seconds and not requiring an intervention like a shock, is termed NSVT, or non-sustained VT. Finally, sustained VT is identified with longer than 30 seconds of sustained ventricular beats, or if an intervention like a shock is required due to hemodynamic instability. It's worth noting that for the definition of ventricular tachycardia, the rate of the tachycardia needs to be greater than 100 beats per minute. A ventricular rhythm with a rate less than 100 beats per minute usually falls in the category of an AIVR, or an accelerated idioventricular rhythm. Let's talk about the mechanisms by which ventricular tachycardia occurs. There are 2 main mechanisms. The first, and by far the most common, is due to a reentry circuit. Oftentimes, patients will have small areas of myocardium where electrical impulses split and conduct in multiple directions. For example, around an area of scarred myocardium that no longer conducts normally due to a previous MI. This is not inherently an issue unless one of the two pathways is disproportionately damaged, delaying the electrical conduction in that direction. It's shown here. Under the right circumstances, an impulse that conducts quickly down the healthy pathway can wrap around, conduct retrogradely up the damaged pathway, and create a reentrant circuit. This is a similar phenomenon as to what occurs in the slow versus fast pathways in the AV node in AV-NRT. The second is due to triggered activity. One such example of this is the so-called R on T phenomenon that leads to torsades. Note how in this strip there are two normal sinus beats, followed by a premature beat. Between the first and second normal beats, the ventricular myocardium is able to fully repolarize and prepare for another depolarization, i.e. the T wave of this sinus beat is completed. After the second beat, however, the premature beat falls during ventricular repolarization. In other words, the R wave falls on the preceding T wave, the R on T phenomenon. During this phenomenon, part of the ventricle is properly repolarized and ready to conduct another impulse, whereas the rest of the ventricle is still refractory. This electrical imbalance is the perfect setup for reentry circuits that lead to torsades, usually occurring as the result of ventricular activities from what are called early after depolarizations, or early depolarizations triggered usually by catecholamines, hypokalemia, or in the context of QT prolongation greater than 500 milliseconds. Many of you have probably heard some quick and dirty tricks to distinguish between VT and other wide complex rhythms, but unfortunately not all of them are sound, so let's quickly talk about a few common misconceptions about VT. The first one I'd like to talk about is the idea that VT is always fast. In fact, heart rates in SVT actually tend to be faster. In a reentrant ventricular rhythm, usually relying on cell-to-cell depolarization, that impulse can only really travel so fast, whereas a wide complex rhythm starting from the atria is usually conducting to the ventricles at least partially through an intact conduction system, which speeds up ventricular depolarization. Practically, though, there's too much heart rate overlap to be super clinically useful, although it's worth noting that, for example, VT with heart rates less than about 150, which is the definition of what is usually termed slow VT, is more common than you might otherwise think, especially if patients are on antiarrhythmics, in which case even slower rates with VT with heart rates less than 130 or even 120 are possible. The next myth to bust is the thought that VT is always hemodynamically unstable. In reality, depending on the study you look at, between 12 and 70% of monomorphic VT can present with normal blood pressure. In contrast, SVT can be very poorly tolerated, especially in young patients with some form of outflow obstruction like hypertrophic cardiomyopathy. For example, this is part of the population of athletes who die suddenly while exerting themselves in their sport. Don't assume that somebody is more likely to be in SVT just because they're in a wide, complex, fast rhythm while asymptomatic or minimally symptomatic. Finally, there is the myth that an extreme right axis deviation, otherwise known as a northwest axis, is diagnostic of VT. The thought here is that if the axis of the heart's depolarization is up and to the right, this suggests that the heart is depolarizing from apex to base. In other words, the exact opposite direction it should, which suggests the ventricles are the origin of the depolarization. However, you can be fooled with this logic. As an example of northwest axis, let's look at this EKG. Note the positive complexes in AVR with corresponding negative complexes in leads 1 and AVL. All this is to say that telling the difference between VT and SVT is really hard sometimes. There are cases where the only way to really be sure is to do an EP study. That being said, let's talk a little bit about an appropriate algorithm to think through when confronted with a wide QRS complex tachycardia. The first thing to think about is the urgency of the situation. How symptomatic is the patient in the current rhythm? If they're minimally symptomatic or asymptomatic, great. You have time to think. Maybe remind yourself of some criteria we'll discuss later that could point you towards VT or SVT and intervene thoughtfully. If somebody is very symptomatic or hemodynamically unstable, then the priority should be in treatment, where electricity in the form of a synchronized cardioversion is your best friend. Refer to ACLS protocols in this case. As a reminder, please sedate people prior to cardioverting. The only situation in which you don't have time to sedate a patient prior to cardioverting them is the situation in which they become unconscious. If they are hemodynamically stable and minimally symptomatic, the next thing to think about are patient-related factors that may clue you in towards the more likely diagnosis. The risk of VT climbs dramatically with age, and any history of structural heart disease or prior infarct or active ischemia. Remember the ways in which VT begins. Young, healthy, structurally normal hearts are less predisposed to VT than old, sick hearts, though VT can still happen in a structurally normal heart too, so don't rule it out. In comparison, SVT is more likely if prior EKGs show a bundle branch block with identical morphology to the current rhythm, or if there is evidence of WPW or other pre-excitation syndrome with delta wave or short PR interval. Finally, as mentioned above, younger people, especially those under 30, are more likely to be in SVT with either pre-excitation or aberrancy. Finally, after you've thought about the above factors, it's time to get in the weeds of the EKG. The next few slides will discuss EKG criteria that, when present, increase the likelihood of the underlying rhythm being VT. The first of these clues we'll discuss is AV dissociation. This refers to an EKG finding where P waves and QRS waves are occurring at different frequencies. It can usually be found on EKG in about 50% of VT, but can be really hard to spot. Let's look at an example. This is a strip of a wide complex rhythm. Note the two arrows denoting likely P waves occurring at different places with respect to the QRS complexes. This is AV dissociation and is strongly suggestive of VT. As an additional exercise, try to find the additional P waves. I found at least two. Here are the two that I found. AV dissociation can cause two other phenomena on EKG suggestive of VT. Specifically, capture and fusion beats. Capture beats, an example of which is shown here, occur when an atrial impulse travels down the conduction system at just the right time to transiently capture the ventricles, creating a QRS of normal width.
These are usually seen in ventricular tachycardia that's relatively slow, because very fast ventricular tachycardias usually don't allow time for sinus beats to conduct through and activate a significant portion of the ventricle myocardium.
Fusion beats are slightly different. This is when a supraventricular and ventricular depolarization occur simultaneously, producing a sort of hybrid complex. These often have odd morphologies, as they are quite literally a fusion of a normal supraventricular and an abnormal ventricular depolarization. The presence of capture and fusion beats on EKG are also quite suggestive of VT. However, as mentioned by Dr. Buxton, catching one of these on a strip is not as common unless the VT is relatively slow. Now let's go through some other more detailed EKG criteria that may lead you to favor a diagnosis of VT. Hopefully, after our discussion, it will be easier to intuitively understand the reason why some of these criteria are in place, but they are challenging and tough to remember offhand unless you practice a lot with them. The first criterion to think about is the QRS duration. Supraventricular rhythms are usually on the narrow end of the wide QRS complex spectrum. As a result, a QRS duration longer than 160 milliseconds favors ventricular tachycardia, but a QRS complex narrower than 140 milliseconds can be either SVT or VT. It's worth noting that this is only valid in the absence of antiarrhythmic drugs.
And the reason for that is virtually all antiarrhythmic drugs that we use slow conduction through the ventricles, and therefore they can make a narrow QRS that's due to aberrant conduction during SVT much wider.
As a side note, if a patient has a shorter QRS complex duration during their tachycardia than their QRS duration was on a previous ECG and sinus, in other words, if their QRS was wider before than it is on your current evaluation, that is a very strong clue that the patient is in VT.
That almost always occurs in the setting of an abnormally wide QRS with an interventricular conduction abnormality during sinus rhythm. You don't see that in people whose QRS complexes during sinus rhythm are normal.
In order to do this, however, it's critical to accurately measure the QRS duration in the lead where the QRS duration is widest. To do this, Beth Israel's Muse software has some functionality that can help. In Muse, the bottom left corner of the EKG display screen has adjustable settings. For example, you can change the layout of the EKG from the default, which is 4 2.5-second strips plus 3 channels of rhythm, to show 12 simultaneous rhythm channels. This will show a longer rhythm strip for all 12 limb and precordial leads, making it easier to directly compare QRS durations and find the longest. You can also change the height of each individual QRS complex, as well as the paper speed, down here in the bottom left, to make it easier to accurately measure QRS duration.
And the QRS duration should be measured from the earliest onset of the QRS in any lead to the latest offset of the QRS, and that may occur in a different lead. That's where the caliper function in Muse comes in handy, in addition to looking at 12 simultaneous leads.
The next criteria to think about have to do with something called ventricular activation velocity. Sounds complicated, but really the only thing we mean by this is how fast is the ventricle depolarizing. The theme of these criteria is that VT starts out as a slow cell-to-cell depolarization wave. At some point during the depolarization, the electrical wave reaches a bundle branch or other fast-conducting area of myocardium, which speeds up ventricular depolarization, but the initial phase of ventricular depolarization in VT is often slower than in SVT. This manifests in a couple of ways on EKG. First, as a wide RS interval. If the time between the onset of the R wave and the nadir of the S wave is greater than 100 milliseconds, that's suggestive of VT. Similarly, if the R wave takes greater than 50 milliseconds to peak in lead 2, that's another clue towards VT. We're also going to talk about some morphology-specific criteria. Take a look at the particular wide complex rhythm you're examining and decide whether it fits either a right bundle branch or a left bundle branch morphology, then look at the corresponding criteria. If your wide complex rhythm happens to look more like a right bundle branch block, there are certain morphologies in V1 and V2 that studies have shown are more common in ventricular tachycardia. For example, a monophasic R wave, QR complexes, or a classic RSR prime or bunny ears morphology, where specifically the left bunny ear looks bigger than the right one, that's more suggestive of VT. Normally in SVT with right bundle branch block, the right bunny ear looks bigger than the left one. Similarly, look at V6. If RS complexes are present, the S wave is commonly bigger than the R wave in VT with a right bundle pattern. Dominant Q waves or monophasic R waves are also clues towards VT. For ventricular tachycardias with a left bundle pattern, morphologies favoring VT in leads V1 and V2 include delays in the R wave peak time or in the RS interval, similar to the criteria discussed for ventricular activation velocity in the bottom left of this graphic, or any evidence of notching in the downstroke of the S wave. In V6, you can look for Q waves, which are suggestive of VT. Okay, so that was a lot of information, but hopefully the ideas at least behind the importance of QRS duration and ventricular activation velocity make some intuitive sense. The morphologic criteria on the right are derived from several large studies of wide complex rhythms, and so are likely a little less intuitively obvious. But now you're aware that these criteria exist, and you can look them up to remind yourself when you need them. There's a great reference article, the citation for which is down in the bottom right, that shows you all these criteria with a little bit of deeper physiologic explanation for the curious. All right, now let's get to some practice. Don't be afraid to jump back in this video and look at the criteria that we just discussed. They'll help you out. First, let's discuss a case you're seeing in the emergency department of a 74-year-old lady. She's got a history of coronary artery disease and prior MI. She's presenting with lightheadedness and stable vitals. You pull up a recent prior EKG, which shows normal sinus rhythm and a prolonged PR interval without any other notable findings. Now, the EKG looks like the following. Pause the video here, take a look at this EKG, and decide for yourself. Is this VT? Okay, let's talk about it. So we have a wide complex monomorph rhythm with a rate of about 150 to 160. Thinking about our ventricular activation velocity, we note an RS interval of greater than 100 milliseconds in the precordial leads. We also note a total QRS width that is very long, greater than 200 milliseconds. Finally, we take a look at our morphology. Monophasic R waves in V1 combined with RS complexes and terminal S wave slurring in V6 is very typical of a right bundle branch pattern. Remembering our morphologic criteria for right bundle branch type wide complex rhythms, we see that S waves in V6 are bigger than the R waves, or an R to S ratio less than 1. So let's summarize. Our patient is a lady with a history of ischemic heart disease who's older, and her EKG shows a monomorphic wide complex rhythm with very wide QRS, delayed QRS peak times, and a right bundle branch morphology with morphologic criteria favoring VT. Overall, very consistent with a diagnosis of monomorphic VT, which was the correct diagnosis in this case. Let's do another one together before we wrap up. Let's say you're seeing a 55-year-old gentleman with a past medical history of heart failure with preserved ejection fraction as well as hypertension who's presenting with palpitations. He's hemodynamically stable, and a recent prior EKG shows normal sinus rhythm with a left bundle branch block. His QRS width in that prior EKG is 120 milliseconds. Now let's look at his current EKG. Again, pause the video, refer back to the previous slides as needed, and convince yourself. Is this ventricular tachycardia? Let's discuss the findings. We again have a monomorphic wide complex rhythm with a ventricular rate of around 150 to 160 beats per minute. Let's look at our QRS morphology. Predominantly negative deflections in V1 with large, broad R waves in V6 is consistent with left bundle branch block pattern. This is consistent with his known prior EKG, and his QRS duration in this EKG is around 120 to 140 milliseconds. Certainly not any narrower than his prior known QRS duration, which would have suggested ventricular tachycardia. Looking in lead 2, we see a fairly normal R-wave peak time of around 40 milliseconds, not above the 50 milliseconds we look for to suggest VT. This can be seen even more clearly in lead 1. The R-wave peaks very quickly. Similarly, the RS duration in the precordial leads is around 80 milliseconds. To summarize, we have a wide complex tachycardia with similar left bundle branch type morphology to the patient's known prior EKG, with signs of rapid initial QRS conduction. We don't really have any criteria apparent to suggest VT here, so we can feel pretty good about a diagnosis of SVT with left bundle branch block. We talked about a lot today, so let's summarize some of the big points. Regular wide complex tachycardia is divided into several categories. These include SVT with aberrancy, either with a pre-existing bundle branch block or a rate-dependent block that becomes apparent only at higher heart rates, as well as ventricular tachycardia, pre-excitation through an accessory pathway, or toxic ingestion. In the vast majority of cases, think VT until proven otherwise. When you're dealing with a wide complex rhythm, look at the patient before you spend any time on the EKG at all. This is probably the most important takeaway from the entire lecture. If they're unstable, the treatment is electricity regardless of the rhythm. Focus on sedating and cardioverting them. You can figure out what the rhythm might have been later. And finally, as we've discussed today, there are criteria that suggest VT that you can use to help you, but nothing is perfect. Sometimes the only way you'll get a true answer is with an EP study, and that's okay. That concludes our session on wide complex tachycardia. Thanks for listening. And Dr. Buxton, thank you for joining us.